Hello and welcome back to the Foot and Ankle Clinics podcast. I'm Megan Ashdown, the managing editor for the series here at Elsevier. Foot and Ankle Clinics is a quarterly publication with each issue focusing on a single topic in foot and ankle surgery. Today we will be interviewing Dr. James Nunley, Goldner Jones Distinguished Professor and Foot and Ankle Orthopedic Surgeon at Duke University. Here now is the consulting editor for the series, Dr. Cesar de Cesar Neto, to lead the discussion.
Good evening, all. So this is exciting second podcast that we do with Foot and Ankle Clinics. And as you guys remember, the first podcast we had Dr. Meyerson as the best editor-in-chief for Foot and Ankle Clinics. And it's a great honor and pleasure and very exciting to have Dr. Nunley here. Dr. Nunley in the foot and ankle world doesn't need introductions. He's well known by any foot and ankle surgeon in the entire world. But I would like to introduce Dr. James Nunley, professor at orthopedics at Duke University, here at the podcast with us today. So Dr. Nunley, thanks so much for being here with us. So I'll let you say hi, and then, I sent you the questions, so we're going to start firing questions on you.
Hey, sir, it's a real pleasure to be here, and I thank you very much for asking me to be included in this series.
Awesome. So, Dr. Nunley, if we were to ask you, like a rapid fire, who is James Nunley in a nutshell? What would you answer? What would be your answer?
Number one, he's a family man who's getting ready to celebrate his 50th wedding anniversary with the same woman in another week. He's a father with 3 children, and he's a grandfather with 10 grandchildren. So that's number one on my list. Number awesome. 2, I bleed blue. That's Duke Blue. I was an undergraduate at Duke in 1965. I've been on the faculty for 48 years, and I wouldn't want to change that for anything in the world. So then lastly, I'm an orthopedic surgeon, and I have loved every bit of my career. It's been phenomenal. I wish other people could experience the things I've been able to experience.
That was awesome. And you're definitely an inspiration for all of us. So that's why it's a great honor for us to have you here. So we really appreciate you taking the time. I put it here because I always ask. I like to hear about people's childhood. So, can you tell a little bit about Dr. Nunley when he was a kid? Where were you? What did you like to do? What do you remember as fond memories? What are your best memories about it?
So I grew up in Charleston, West Virginia, which is the small state, 1.8 million people, and it's the capital of the state. We were not wealthy. We were middle class. When I was in the 7th grade, we moved to the house that I lived in until my mother passed away a few years ago. And the beautiful thing about this in West Virginia is that house was on the top of a mountain. And we had 7-foot picture windows in our living room and dining room, 4 of them. And we looked out over top of the mountains, and you could see for as far as your eyes could see and didn't see another house. And what was spectacular growing up was sitting there and watching it snow, because we had a balcony. And it snowed a lot in Charleston, West Virginia. And I absolutely love snow. So when it got about 6 or 8 inches, the rest of us kids would take our sleds and we would walk about a half a mile down the hill to a golf course. And we had a sledding track that went from the top of the mountain to the bottom. We built a bonfire, and it was an incredible way to grow up. And that's one of my most favorite memories of West Virginia. It's an outdoor state, and my parents would take us to state parks, and we spent a lot of time in the outdoors. So it was a wonderful place to grow up.
That's awesome. Fun fact about it, just from like a dummy Brazilian that doesn't know the United States, when I was driving from Iowa to here, it was very boring, right? Because it was all flat, Ohio and Indiana, flat. And suddenly, after driving for a long time, not even remember how long I was there, it became very exciting, very beautiful, and very, hilly and very like a lot of mountains and curves and things like. So I finally woke up. I was afraid of crashing my car or something like that. It was so that's where I was. And for me as a Brazilian, I didn't know for me West Virginia was the west part of Virginia. So at that point, I found out that it was a state. But anyways,
it was a state, yes.
Yeah.
And you're right. The roads there before the interstate were totally windy, and it was an incredible. You really had to learn how to drive on a single lane or double lane road through these curvy mountains, and it was pretty treacherous.
It is, and it's beautiful. Yeah, I was very positively impressed. The next one I have here is how did you decide that medicine was your path? I mean, how was that decision to pursue the medical career? But I found a very interesting a phrase from you that actually is in your video at Duke website, where you say that you wanted to become a physician since you were 8 years old. You knew you would be a physician, and you knew you would be a surgeon. So that's fascinating. So tell us about it. That's a pretty cool thing.
I mean, I don't know what more to say other than that's the absolute truth. I had a pediatrician, Jack Bassman, that was an incredible human being, and he had a lot of influence on me. They thought I might have had polio when I was a young child and had to spend some time in bed. Anyway, I really liked this man and what he did, and I just knew at that point that medicine was going to be my calling. I'll give you another anecdote. I met my wife on a blind date, and she flew back to Denver the next day, and I told my brother-in-law I'm going to marry her. And I did 1 year later, and people want to know, how in the world did you know? I just say, it's like, how did you know medicine was right? It's just something in your heart that tells you, you know.
That's awesome. That's fascinating. So I was very intrigued by what I read. And then once you got there, and correct me if I'm wrong, but medical school was in Tulane University in Louisiana. Is that correct?
Yes, it is.
So how did that go? How was the medical student or Jim Nunley? What did you like to do? What were your favorite things in medicine during the medical school? What did you like?
Well, when I was a Duke undergraduate, my roommate was from New Orleans. His father was the head of OBGYN at the Ochsner Clinic. So we would sneak down for Mardi Gras and stay in the city. And I said, man, this is a really, really nice place. I think I might like to go to medical school here. So sure enough, I applied and got into Tulane. And it was a very exciting city. Coming from very small town, West Virginia, small town Durham, to a large city like that, it had so much to offer. And we had the Super Bowl there. We had good athletics. Medical school was incredible because we had Charity Hospital, and people have no clue what that's like. But Charity Hospital was one of the two largest hospitals in the United States. And we had, I think it was 22 floors. And the top floor was a basketball court. And for the med students, we could go up there and play basketball, but you could also slip down to the cafeteria and eat for free when you weren't supposed to, because as medical students, we had absolutely no money, none whatsoever. So the way they treated you in medical school, I mean, when I was the fourth year medical student and I was on the OB service, they only woke me up to do twins or breech. We'd had so many deliveries as third year. I mean, the amount of experience that you got at Charity Hospital was difficult for anyone to understand. And
wow.
That was really exciting. Plus, the city itself was a great place to be.
A lot of hands-on, right? I would expect.
Lots of hands-on.
And then residency was UCLA for general surgery, and then Duke for orthopedics. How did that go? Well, how was it? Was it a different system before? Or you did general surgery and then you changed your mind and went into orthopedics, or it was like a sequence of events?
So when I was at Tulane, I knew I was going to be a surgeon. And we had general surgeon Ted Drupanis, who was the general surgeon. He was one of the most gifted teachers we'd ever had. And he convinced me that I definitely wanted to do surgery. And he had an unexpected death. So during my senior rotation, I rotated on orthopedics with Henry LaRocca. And he was an incredible individual, spine surgeon. And he convinced me that orthopedics was the way to go. So at that time, you had to do 2 years of general surgery before you could do a residency. So I wasn't totally positive that orthopedics was going to be what I wanted to do. So I applied, and being a small town boy, I'd never been to the West Coast. I said, I'm applying to San Francisco and UCLA. I want to visit the West Coast. So I went out there to UCLA for 2 years and had a great experience. Bill Longmire was the head of surgery, and he was a phenomenal person, one of the best liver surgeons in the country. But while I was there, I rotated on the orthopedic service with Harlan Amstutz. And most people in orthopedics will know he was one of the giants in total hips. And Jerry Feinerman was there, and he was the guy that invented the total knee. And so he had the unicondylar total knee, and Lynn Marmer had the mobile bearing total knee. So I got great experience in orthopedics, and I said, this is a whole lot better than the smell you get from general surgery when you open a belly and it's pus, pus, pus. So there was no question at that point that I was going to go ahead and go into orthopedics.
So that's when the total joints started getting into you, right? It started early. It started early.
Exactly. Yeah.
And then you went into ortho, and you knew from the beginning that was your mission, that was it. How did that go?
It did. I had applied to orthopedics at Duke when I was a first-year intern. So that was 2 years before. And I had told UCLA I was going to come there, but then I decided I would really like to go back to Duke. So I called Leonard Goldner and asked him, I said, I've applied and you accepted me, and I'd like to take it. So he brought me back for an interview, and we sat down there, and he said, well, what do you want to do in life? And I said, well, I want your job. He said, what? I said, yes. He said, well, I can give you a job, but I can't give you my job. As luck would have it, some 30 years later, I did become the chairman of orthopedics, but I wanted to get back to the East Coast. I was married, and we came back to Duke, and it's been a phenomenal experience.
That's amazing. Well, you're definitely a hunch gas guy, and you make it happen, right? What you promise, what you feel, you make it happen, and that's awesome. And then that's an interesting one, because I know a little bit about the story, because I've seen you telling before, but some people don't know about your background in hand surgery, and then foot and ankle, and switching to foot and ankle. So how did that go? Like, how did you start with hand? And I know you had a lot of experience with hand surgery. And how did you apply that? How did you decide to switch to foot and ankle? Why did that happen? And how did you apply everything that you learned from the hand surgeons into foot and ankle? What was the big thing in your career that hand gave you the background for it?
So during residency, I liked every rotation I was on, but at that time, microsurgery and replantation was starting to explode. And I found that was technically challenging to put on fingers and sew blood vessels that were 0.5 millimeters in size. And so I said, I think I would like to go ahead and go into hand surgery. It was just really exciting because, total joints were around, but they weren't exploding. Sports medicine was not much of anything at that time. It just basically didn't even have scopes. So here we were under the microscope. We were doing things that people just didn't seem possible. We'd move toes up to hands, and this was really exciting. So I joined as a hand surgeon. But then my career took all kinds of deviations. In my second year on the faculty, our pediatric orthopedist, he died. No male in his family ever got over the age of 40. So I inherited a myelodysplasia clinic with 200 kids in it. And I became the pediatric orthopedic surgeon. And I had to operate on their spines and their feet and everything like that. So I was glad when we got a pediatric orthopedist and I could get rid of that. So I shared an office with the total joint surgeon, and the third or fourth year I was there, he ruptured a papillary muscle in his heart. So he had to have an aortic valve put in. Well, his surgery schedule was booked up for 4 months, and his secretary said, Jim, you're going to have to do all these hips and knees. I said, okay, I kind of like those. So for years, every Friday, I do 2 or 3 total hips or total knees. I did those for over 20 years. And
wow.
I really, really enjoyed doing that. And that sort of gave me the background for understanding joints and what needed to be done. So as time went on, 1990, I asked Urbanic, who was the chairman, I said, I would like to restart the foot fellowship here at Duke, because Leonard Goldner had stopped in 87 and been nobody doing it. And he said, okay, if you can find the funding, you can do it. So I went around, got some training, and found the funding. And so I started the foot fellowship in 1990. And as you know, we've continued to have that fellowship to the present. So I would have 2 operating rooms, one for hand and one for foot. And that was really, really exciting. But people ask me then, why did you give up hand surgery? And why foot? And the answer is hand surgery almost never cuts a bone. So you don't have a scorecard. You can't put an x-ray up like you do with the bunion. And it's either straight or it's crooked. There's just no question. And hand surgery, you're fixing flexor tendons, you're fixing nerves, you're doing soft tissue interpositions. And you could do the greatest job in the world with a flexor tendon and the finger doesn't move. So it was easier to get feedback right away from something a little bit more difficult. And then you say, well, what about sports? I mean, my goodness, you just put the scope in and look around, cut a little meniscus out. Nobody knows how you've done. Again, there's no scorecard. So foot and ankle, we're doing osteotomies. We're correcting everything. We're doing exciting things that orthopedic surgeons had abandoned for so long. They really, really were not interested in it. And the beautiful thing about the hand surgery was it brought me an appreciation for instability. We had carpal instability. We had soft tissue that we had to manage. And so I learned very quickly that the foot, you needed to be very, very careful with how you handle the soft tissue. It's one thing if you need to put a skin graft on the hand, but if you got to put it on the foot and the patient can't walk or because you've messed up the skin, that's a real problem. So the techniques that I learned, and then, of course, I had experience with vascularized bone grafts and microsurgery, so I could bring all of those to the foot and ankle from things that I had learned in the hand. In my experience with joints, the one thing that I learned early on was that if you reduplicate anatomy, then the kinematics will follow. In the original total knee, the medial and lateral femoral condyles were the same. And we know that's not right, and that's why the early knees didn't do well. So when I started doing total ankles in 1987 and subsequently since then, I've always concentrated on let's try and make sure that we are reduplicating the anatomy that the patient has, because if we do that, it's going to succeed.
Yeah, and that's very clever. And it's amazing. I didn't know about the total hips and the total knees every Friday, plus the hand, plus the pediatrics. It's a complete, fully trained orthopedic surgeon. That is amazing. I can barely do foot and ankle, so that's awesome. So you mentioned that already, but I wanted to learn and that the people that are listening, you mentioned about you being the chair of the department, and I know how much bureaucracy, how much paperwork, how much dedication you need to deal with the entire department. So how? I know it's impossible to tell all that, but like what exactly do you remember as being things that you like to do as a chair and the things that you hated the most that came with the job?
That's a really good question, because the first several years, of course, we were a division, and then I was fortunate enough to make us a department, which gave us a lot more leeway. And so the things that I enjoyed the most were, number one, I was dedicated to taking care of patients. And I saw that when I first came to Duke, there were 7 attendings, and we took 8 residents a year, 40 residents. And so I said, there are lots and lots of people out here that need our help. And it's ridiculous to keep this faculty that small. Let's hire instead of saying, I want everybody's OR schedule to be booked up for 4 months in advance, let's hire enough surgeons that we can take care of the population, the people that want to come here for outstanding clinical care. And so that was one of the things. I started the community program where we put surgeons that I hired into the hospitals around Durham and the surrounding area, and it worked out very, very well. So I loved that. I loved also the ability to interact with residents because, you can't just say, I do it this way because then they're going to say, well, Dr. Nunley, that's not an explanation. I think you should do it this way. And they keep you sharp because they're always questioning, just like your children, why you do something that you do. And if you're still doing the same thing you did 5 years ago, you're in trouble anyway. So I love the fact that interacting with residents and fellows kept me really, really sharp. And they stimulated my interest in research. So research at that time was very difficult, very difficult. One of the things that I did was to be able to bring in and hire clinical nurse coordinators. I paid for biomechanics. I paid to set up a registry for joints. And so it made it, the residents would come up with an idea that they wanted to do research, and they would try and put an IRB in. And 6 months later, the IRB would come in and they'd be gone from that service. And I said, we can't have that. We need to make this turnkey so that they can get things done that they're interested in right away. So I tried my hardest to set up a research program that allowed the residents and fellows to follow their goals.
That's awesome. And I can tell that it's still there. I'm not sure that the IRB is that quick anymore, but it's definitely the fire for the research and the fire to ask the questions is definitely there. And I'm sure that your inspiration and your work is reflecting currently into what we do at the university and at the foot and ankle and the orthopedic department. I put it here because I really want to hear. You already said a little bit of this, but I really want to hear how did Duke influence Jim Nunley and how did Jim Nunley influence Duke? I know it's a tough question, but it's like for you to think about it. What do you think would be what you would answer for that?
So Duke taught me a lot of things. When I came as a freshman undergraduate, I had done pretty well academically. And I went into the classroom and I knocked it out of the park the first semester. So I decided to take these advanced courses and I got busted. I got busted. And then I had to take a German, 2 years of German to go ahead and get my Bachelor of Science. I got 2 C's and 2 D's. I said, man, I'm not even going to be able to get in medical school. These people have knocked me down. That's when I learned that you better start paying a lot more attention. You better start learning to work harder. And that really made a big impression on me. But people ask me all the time that I've looked at other jobs. They say, why do you stay at Duke? And I say, there's one reason and one reason only. It's Duke basketball. And so they laugh. But I've had tickets since the day I got there, which was before Krzyzewski. And as an undergraduate, we had incredible sports, and I would go to all of those. And I loved the association with sports and with orthopedics associated with sports. And so Duke taught me that if you work hard, you can play hard, but that'll get you success.
Amazing. Yeah, you definitely bleed blue. So that's very beautiful to watch and to have as a example for all of us in whatever we do. So thanks for that.
Taking a quick pause here to let our listeners know that they can receive an exclusive discount on an issue of their choosing by visiting us.elsevierhealth.com/expert.
We're going to switch a little bit from Duke, but there's one that I have to ask because I won't give names, but there's a famous surgeon that when I decided I was coming to Duke, he told me, if I see you saying that at Duke we do that way, I'm going to kill you. I'm going to fly to Durham and I'm going to shoot you down. And so what is that? At Duke we do like that, the Duke way. What is the Duke way? Explain to us.
Yeah. I wish that would go away because I do find that obnoxious too. Because one of the people who came down here said, "Well, this is the special surgery way, and we need to drape our total hips this way," and it used to grate on me. So I know that this grates on people, but we try and establish a system where things are done the same way every single time. You do the same thing over and over and over again, you get good at it, and there's very little margin for error. So yes, I've heard that expression, and I wish it would go away. So please don't repeat it again, please.
It did, and people make fun in a good way with great feelings about you and Dr. DiOrio and the Duke legacy for sure. But I thought it was interesting to talk about it. You mentioned the sports, so I know about your passion for sports and your passion for Duke sports specifically. But I wanted to understand better, how did you get involved with professional sports and college sports? As I know how dedicated and passionate you are about taking care of the athletes, and I know you did it for a long time. You're still doing. How did that happen? How did you how to start doing that? If someone wants to pursue that specific part of the career, how did you do it, and how would you recommend people to do it?
So have you ever heard the expression, the right place at the right time? So
sure.
In 1992, this female basketball player who was 6'8" was recruited to Purdue, and she had foot pain for 3 years. And when they got to Purdue, they saw she had a non-union of her tarsal navicular. They canceled her scholarship. So Coach Gestencourt at Duke said, "Well, we're going to recruit her." And Kevin Spear was the head of sports medicine. He said, "Well, hell, Nunley can fix that." I'd never seen one in my life. I'd never fixed one in my life. So as luck would have it, I fixed her, and she went on to become an All-American and went and played in the WNBA. Well, Tom Butters was the head of the athletic director. And when Frank Bassett was in charge of sports medicine, he did everything on every patient. And he did a scapholunate dissociation on one of our All-American basketball players. And after he left the OR, they called me in to come and fix it right. And similar things happened. So when Kevin came, Butters said, "We're only going to have the experts in that area take care of our athletes. So Kevin, you're a shoulder guy, and we're going to have this guy's the knee guy, and we want Nunley to take care of the feet." Well, okay, so that's exactly what happened. And so, Duke's had some profile players. And so, yeah, probably the best story was Elton Brand, who was the number 1 pick in the NBA. And he had a Jones fracture, and I fixed his Jones fracture, and he played against Carolina 6 weeks later, scored 17 points, had 10 rebounds. And the TV announcer said, "Man, if you got a Jones fracture, you want to go to Duke and have Nunley take care of you." Well,
that was all set. After that, it was all set.
So, and that's exactly how it happened. So then the next thing that happened was that a lot of these players then went on to professional careers. And then, when I had to operate on Grant Hill, and then I started seeing all the NBA players, or a lot of the NBA players. And so it just kind of morphed into it. So I'm not sure that there's a way now for everybody in foot and ankle to get in that, but they certainly can get into taking care of athletic injuries. And it's a huge part of our practice. Achilles tendons, ankle instability, foot fractures, these are things that if you have an interest and you start taking care of them, you'll get the high school teams, because, the high school sports medicine doctors most of the time are knee or shoulder people, and then the local colleges, and then you can morph into it if you're really interested and start seeing the higher level ones. But yeah, it's been a very rewarding career, and I've had some ups and downs, but I've enjoyed it.
Okay, so it ended up happening, by chance, right?
By chance.
That's great. So we're getting to the final questions here, but this is supposed to be very informal. But I do want to talk to you about research, right? Because as a prolific researcher and having trained so many foot and ankle surgeons and orthopedic surgeons as a chair of orthopedics, I know about your passion for research. But I wanted you to tell us exactly how did you started getting involved with research? How did you, once you felt that you were ready for it, that you could, mentor people and it could be principal investigator in research? How did you plan to really boost your research and how to ask the right questions, right? Ask the right questions and find a way to try to answer them. It's tough because we never answer completely, right? But we always improve it. But how did you navigate through that? And what is the advices that you could give to younger foot and ankle surgeons and orthopedic surgeons of how to start and go to the, a pathway with a reason?
Well, first of all, you have to understand or have a desire to do this in a specific area. And you make a mistake if you just try and shotgun and write down every single case report that comes up that's kind of interesting. So what happened with me, very much like what happened with the total ankles, is we started doing the free vascularized fibulas, Jim Urbanik, myself, and one or two others. And we collected the data on 2,000 of these. So we started to be able to publish the results in kids with Perthes, in people that had dislocation. And it just morphed into, when you have a database that you have contributed to for years, then you can just pretty much mine that at your desire. And that was where I early got my start in clinical research. In basic science research was a little different. We had a biomechanics lab at Duke run by Rich Glisson, who was a very gifted engineer, and he loved to work with orthopedic surgeons, and he was an employee of orthopedic surgery. So we would go to Rich with ideas like I did one of my earliest papers was on fixation of phalangeal fractures with plates or screws, and so we started doing biomechanical testing. Well, that opens up the field of everything you wanted to do. You could do biomechanical testing on total joints on the cadavers, and so with that lab down there, anytime a student came up with an idea, we would go with Rich and work out the project and get it done. And so that worked out really, really well. Obviously, the most successful thing I've had was starting the total ankle database in 1998, and we have over 2,000 ankles in there. And so just by collecting data, just by understanding that you don't know what you don't know, you want to ask questions. And if you have big data that you can mine, you can answer some significant questions. And so that's one way to approach research. You have to be able to do it where there's a group, where there's other people, because it's unlikely that one person will accumulate enough data in his lifetime to be able to do something like that. Mm-hmm. But I think that's a really great way to do it.
Those are great advices. I look here and, there's definitely different places to see it. So it definitely shouldn't be very precise, but Scopus gives you 367 publications. And I have the hard question and the tough questions to ask you. What are your three favorite publications? Of course, you won't be able to tell about results and things like that, but maybe the subject and why. Why are they're your favorite studies?
Well, my first one is the Roger Mann Award paper, the prospective randomized study on mobile bearing versus fixed bearing total ankle. When I started with the star ankle, I thought that the mobile bearing was the way to go. And then in 2007, we had the Salto, and always was a debate. Every meeting we went to, which is better? Is it better to do a fixed bearing or mobile bearing? And it was the U.S. versus Europe. So to me, to put that paper together, to get my partners to help me collect 100 patients and to randomize them, and the patients accepted it, that was really, really special.
Amount of work, yeah.
Really, really special, yeah. That's my favorite paper. After that, I really would have to scrounge down hard to think about it. But I will tell you this. We talk about ankle instability. And I was interested in this and had several publications in it. Well, when Lou DeFreight came, he's an engineer that I hired, and he was big on using biplane fluoroscopy with MRI to study joints. So I said, let's study lateral ankle instability. And we had several students that worked on that, and we showed that the kinematics after you've had a lateral ankle sprain translated to stress on the anterior medial aspect of the talus. Okay, and I mean, it was very clear from the surface studies on the MRI. So that sort of explains a lot of why we have that type of arthritis, by the way. So I said, well, gosh, if that's the case, can we reverse that with the Brostrom? So we recruited patients. We did the Brostrom on them. We brought them back a year later, and we did the same biplane fluoro with the MRI. We showed we completely converted them back to normal kinematics, period. Question answered. So you shouldn't leave an unstable ankle because we know it's going to wear. And for me, that was not just one paper. That was a series of them, but it made a big impact.
Yeah, that's an awesome paper. Still a great example for all of us. We skipped some of the questions because I know I sent you a lot of questions and I don't want to overwhelm you, but we can't leave AOFAS out of it, right? So as a past president of AOFAS, what do you think what did you enjoy the most of being part of the board and being involved with the leadership, and what did that influence in your career and in your legacy? How do you see that?
That's a really good question, because when I started going to the AOFAS meetings, I realized that this was a group of individuals that liked one another. There was no nitpicking. There was no. I walked up to Bill Hamilton and we played golf together, and he didn't know me from Adam. And it was like everybody got along, and it was just really, really tremendous. And of course, I had a legacy of people that had been presidents from Duke. So Leonard Goldner had been president, and Lamar Fleming and Bob Adelar. And so they got me involved in the politics, and I was fortunate enough to become the president of that society. And that was well before I had any leadership role at Duke. And I learned how tough it was to herd a group of people together to come to a consensus. And how to get into a meeting. I learned a lot from Don Baxter. Anytime there was a problem, let's study that. Let's table that. Let's get a committee to study that. And so there were some lessons like that worked out really well when we had fights in the Department of Orthopedics. That's a great idea. Let's study that. And I learned too. One of the things that I tried to do in the Foot Society was to incorporate our podiatrists. And this is still an area that causes angst almost as bad as if you're a Republican or a Democrat in this country. You know, podiatrists are not going to go away. And just like orthopedic surgeons, we have good ones and we have some that may not be so good. And to try and ignore them and not incorporate or embrace them and let them come and study and learn from us, I felt was wrong. So I was a big advocate of allowing the podiatric community to come and take our courses and learn from us. And that helped me at Duke too, when we had some difficulties with certain staff members that weren't getting along. And so how are you going to be able to incorporate this when people blatantly just either discriminate or hate you? You have to find some ways to solve that and to get them involved. And so that helped me a lot.
Yeah. Well, that's this politics. I didn't know that you were president before you were in the leadership of Duke. That was definitely very important for you to be able to navigate through these waters, tough waters, for sure. That's very interesting. I think people know that Dr. Nunley is not retired. He's partially retired. He's not operating anymore. He's on patients, but he's still in the OR and helping us and operating with Dr. Easley, but still seeing patients. And we have a very important mission. So of continued the education and the teaching of young orthopedic surgeons and young foot and ankle surgeons. So I wanted to know what is the James Nunley mission in the next coming years? How do you feel as you're remaining? Not that you need to do it. You already did a lot for all of us. But what is your mission? What do you feel like in your heart that is still your mission to keep going?
That's a great question. So I did decide 2 years ago to stop operating, and Number one, I didn't have the stamina to continue to operate 12 hours a day. That was too much. Number two, I started having bad arthritis in my thumbs, and I just didn't feel like technically I was as good as I wanted to be. And I said, okay, I'm not going to take on these cases and harm anybody, but I still have enough experience that I can help people. And so I'm going to assist. And I assisted DiOrio in cases and Easley on cases. And I love to do the cadaver labs with the fellows. As I started the cadaver teaching program here for the fellows last year and plan to continue to do that and do labs across the country, because I think I can instruct pretty well on how to do these surgical techniques, and I don't have to do them myself. So it gives me a lot of pleasure to do that. And continuing to solve some of these difficult problems and continue with the research is what's going to keep me going. Plus my 10 grandchildren. They say, Granddad, we got to do this. Take me to the lake and go water skiing. I said, okay.
Let's do it. Yeah. Well, that's awesome. And you need, and I think it's a real blessing. I think our fellows and our residents have a real blessing to have the chance to learn from you and interact with you. It's a unique opportunity. So thanks for all your dedication and your unbelievable experience. And you're always welcome to come and join me, because I would love to learn from you as well. So my doors are always open for you. If you want to come help me and teach me, the doors are always open for you, as you probably know. We're almost done. What are your plans for the retirement? We talked about the teaching part, right? And you talk about your grandchildren, but what do you want to do? Like, now that you would have potentially more time, what are the things that you always wanted to do that you think that now you're going to be able to do? Tell us about it.
Travel is definitely something that my wife and I have been all over the world. We've been fortunate enough to be in many, many places, but we've never been to the Galapagos. That's on my list, my bucket list. We've never been to Yellowstone Park in the United States. That's on my bucket list. I try to make all 50 states, and I went to South Dakota last week, and so I'm down to 2. North Dakota I haven't visited, and Alaska, and I want to go see Mount Rushmore and go to North Dakota. Whether I make it to Alaska or not is a different story. But my wife and I would like to get in our car and travel from national park to national park as we cruise across the United States, because it's such a beautiful country. There's so much to see, and we've seen the world, but we haven't seen our own country. So we're planning to do that.
That sounds very exciting. Make sure that you take a lot of pictures.
I always do.
So it's my last question before I thank you for being here. But I really would like you. I know it's tough, but if you could give like 3 quick advices to young orthopedic surgeons, and of course here is more foot and ankle, but as an orthopedic surgeon, 3 advices for young career people, maybe based on mistakes that you made or shortcuts that you were able to get that it was beneficial for you, or maybe something that you learned from your own mentors. If you could give 3 advices, not just for specific research or academic or surgical or clinical, could be life advices. What would it be? What would be your 3 advices for young orthopedic foot and ankle surgeons?
Number 1 will always be family. That's the single most important thing you're going to have in your life. And a happy wife is a happy house. So you cannot spend so much time and completely ignore your family that you jeopardize what will be your real legacy. Yeah, your legacy can be fellows, but there's nothing more than your children and that's your real legacy in life. So you've got to carve out time and pay real attention to your family. That's number 1. Number 2, never forget that what you've learned is from the shoulders of giants. And so many people feel like, gosh, these people, they didn't know anything. But we only succeed in life when we recognize that people have gone before us, struggled, found something, and yet we may push that farther. But always respect the fact that somebody has been there before you, and think about that. And lastly, hard work will always succeed. Shortcuts rarely ever succeed. And yes, I've made shortcuts. Other people have taken shortcuts, and that's not a good way to get there. It's the tortoise and the hare. Just remember, slow and steady gets there, and don't take the shortcuts.
That's awesome, Dr. Nunley. Well, we stayed on the time, maybe a little bit more than what we promised you. We know how hard it is to take time out of the evening from family, so we're really honored and happy and grateful for you to be here. I think it would be awesome for people to watch. And again, thank you for being a role model for young foot and ankle surgeons, and not just young, but all the foot and ankle surgeons, and for being an inspiration for our specialty, and for all that you did for patients and for the specialty. So I really appreciate it. It's an honor for me to be interviewing you. It was a great pleasure and great honor.
Thank you.
Thank you for joining us for this episode of the Foot and Ankle Clinics podcast with Dr. James Nunley. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Foot and Ankle Clinics podcast on Apple Podcasts and the Google Play Store. Thanks for listening.